Hi, I'm Sohaib, one of the NICU fellows here at Connecticut Children's Medical Center, joined by Dr. Hussain and Dr. Kellner, our attending neonatologist. Today, we will demonstrate how bedside lung ultrasound can rapidly detect pneumothorax in the NICU setting. Lung ultrasound is now a core part of neonatal focus. It gives real-time bedside assessment without radiation and is often faster and in many scenarios as accurate as a chest x-ray. In this video, we will cover three essentials. First, when to scan. That is the clinical triggers that should make you reach for the probe. Second, how to scan, including machine setup and a step-by-step anterior and lateral pleural exam, including M mode. Third, what to see and do. That includes normal versus pneumothorax signs and how these findings drive urgent management. Regarding indications, scan for pneumothorax anytime you see sudden respiratory decline, including desaturation, new work of breathing, or asymmetry, including unilateral breath sounds or chest rise. In a ventilated infant, any unexpected high pressures or worsening oxygenation, and then an hemodynamic instability such as bradycardia or hypotension. And if there are high-risk events such as vigorous PPV. There are no absolute contraindications to using lung ultrasound. Accuracy improves with training and a structured protocol. However, know the pitfalls. Dressings, lines, or tubes can block windows. Unstable infant may tolerate only limited views, and then conditions such as pleural adhesions and subcutaneous emphysema can obscure the pleura and mimic air. Regardless, lung ultrasound is well tolerated with no ionizing radiation. Discomfort is minimal and limited to probe pressure or gel. As always, apply your clinical judgment in interpreting findings in context to avoid false positives or negatives. This is an example of a portable bedside ultrasound unit with attached high-frequency linear and hockey stick probes for imaging. Regarding probes, for term and late preterm infants, use a 10 to 22 Hz linear probe. For extremely low birth weight infants, a hockey stick probe up to 18 Hz provides better resolution in narrow rib spaces. Essential gear needed includes a portable point-of-care ultrasound machine, the high-frequency linear or hockey stick probe, warmed ultrasound gel, probe covers if sterility is needed, and standard bedside monitors. Have towels or positioning rolls ready and keep the infant warm. Most scans are done with the infant lying supine in incubator. Gently adjust the arm or rotate the torso if tolerated to access lateral spaces. Avoid excessive lifting or turning. Our goal is a quick, minimal disturbance sweep that still visualizes all anterior and lateral zones. Scan each hemithorax systematically, divide into anterior, lateral, and posterior zone using the parasternal line, anterior axillary line, and posterior axillary line as landmarks. Sweep in the arrowed direction within each zone. Here is a video to demonstrate how to scan in 3 zones. Sweep each intercostal space to follow the pleural line. When finished, gently wipe off the gel with warm gauze. This is an example of a normal lung ultrasound with a bright smooth pleural line framed by rib shadows, the classic bat sign. Look for the lung sliding, the movement of the pleura during respiration that appears as a shimmering. Deep to the pleura are equidistant A lines. In pneumothorax, notice the pleural line is static with no movement or lung sliding. and then A lines predominate across the field. Finding a lung point sign, the transition with no sliding to sliding of the pleura is diagnostic. That is not shown here. Scan multiple anterior and lateral spaces in the spine neonate to confirm and estimate the size of pneumothorax. On using the M mode, there is significant difference between a normal lung and lung with pneumothorax. Normal lung shows the seashore sign. Static chest wall lines, since normally there is no chest wall motion, and then there is a positive motion of the pleura resulting in granular beach appearance below the lung sliding. In comparison, on M mode in pneumothorax, there is barcode sign, parallel lines above and below the pleura, indicating absent pleural sliding. Thank you for watching this video.